Good afternoon, or in a moment soon to be good afternoon, and thank you again for coming to Grand Rounds. We really have two great speakers from both our faculty in hematology and medical oncology. Just some quick announcements before we start. One is, we had a town hall a few weeks ago, and we didn't have as much time as I think we all would have liked for questions. But actually, our consultants, Whitecap, is putting together a short survey. I emphasize short because everyone's time is valuable, which will be coming probably in the month or so to get your feedback of what you sort of see the opportunities and priorities are for our cancer center that we want to sort of layer into the work that's going to go into developing a strategic plan for the next decade. So we'll follow up with more information on that, but stay tuned. The other is, be aware, for those of you who have the privilege of voting on Doximity for U.S. News and World Reports, that we've heard a rumor that they've sort of began to start the voting on that. So we'll offer more details when we can all officially vote. But for those in the room who can vote, please do not forget Yale Cancer Center, Smilow Cancer Hospital when you vote, when you cast your vote. And then lastly, we made a wonderful announcement yesterday that Dr. Pamela Coons is coming to lead the GI gastrointestinal cancer program at Yale and Smilow. And Pam is really a superb GI oncologist, investigator currently at Stanford University, who will be joining our faculty this summer. So turning now to the agenda for the day, again, two great speakers, both of whom I think are building a terrific portfolio in clinical investigation and translational research. And we'll start first from the advantage of the hematologic malignancies. Our first speaker is Dr. Amer Zeidan. Amer, as you know, is an associate professor of medicine at Yale, specializing in the investigation and clinical care of patients with myelodysplastic syndromes and acute myelogenous leukemia. And really, since his arrival at Yale, he has now become a nationally and internationally recognized expert in both clinical care and really understanding these diseases towards fundamentally improving the outcome for patients. Amer received his medical degree from University of Jordan in Amman. He completed his residency at Rochester, and we were very fortunate a few years ago to recruit him from Johns Hopkins, where he has really become an invaluable member of our faculty and a leader in this field. And Amer is going to tell us about his work taking the revolution of immuno-oncology and moving it into myeloid malignancies. Amer, thank you.
Thank you, Charlie, for this kind introduction. Thank you, everybody, for coming in today. So, as Charlie mentioned, my work really focuses on myeloid malignancies, where I do both effectiveness research as well as clinical translational work. And I have a special interest in immune checkpoint inhibition within this field. Yale is a very well-known place where a lot of immune checkpoint inhibition studies and immunology has been going on for many years. And we wanted to take the same approach for myeloid malignancies. So as a busy clinical investigator, I work with a large number of companies which are involved in this field. Just a couple of introductory slides. So basically, myelodysplastic syndromes, many of you know that the introduction of hypomethylating agents has been a major breakthrough. However, as you can see here, patients with high-risk MDS still have very poor outcomes. So this is some of our real-life analysis that we've done within large databases. And what you can see here is that the median survival is 11 months from the time of diagnosis for high-risk disease, despite the use of azacitidine. In a larger data set that included bone marrow transplant was only 17 months. And once these agents stop working, the survival is really 5 to 6 months. So clearly it's an area of need, of unmet significant need. And one of the groups I think that have been particularly interesting to study in this setting has been immune checkpoint inhibition. So this is a slide that I used to update basically for every talk, and then I gave up because every month there are two new indications basically for immune checkpoint inhibition in solid tumors. What I'd like to draw your attention is that for malignant hematologic malignancies, the only indications really have been so far only in lymphomas, in primary mediastinal lymphoma and classical Hodgkin lymphoma. And there has been a lot of interest to explore this in myeloid malignancies. As many of you know, allogeneic bone marrow transplantation is actually the most potent anti-leukemia treatment that we have, and it's largely thought to work through basically graft versus leukemia effect and immunological effect. And it would make sense that some of those immune manipulation activities would actually work also in myeloid malignancies. So the immune checkpoint inhibitors that have been studied in myeloid malignancies basically are really among the same ones that have been studied in solid tumors. As you can see, the traditional ones, the PD-1, PD-L1, and CTLA-4 were the first one to be studied. What you can see here is Ipilimumab, Pembrolizumab, Nivo, Durva, Atezo, and Nivolumab. All these 6 agents are actually being studied in myeloid malignancies. And I will divide my talk into 2 parts, where I talk first about myelodysplastic syndromes and the use of immune checkpoint inhibition in that area, and then go to acute myeloid leukemia and the use of those agents. And in the last few minutes, I will talk more about what I would call second generation or novel immune checkpoint inhibitors, which focus on TIM3 pathway and CD47, which I think are also making significant contributions to this field. Apart that, I will not be talking about today for the sake of time, is the use of agonists, basically like the OX40. Those are also being studied, but the focus today will be on immune checkpoint inhibition. So this is a study, I think, that attracted a lot of attention when it came out in the New England Journal of Medicine 2016. It was a phase 1 study from the Dana-Farber group in which they gave Ipilimumab, the anti-CTLA-4, for patients with relapsed hematologic malignancy after relapse. And it's a small study, only 28 patients, but they had what I would call significant results in a very highly refractory patient population. They had 5 patients out of 13 patients who developed complete response. Most of these patients have the response in what we call extramedullary relapse or myeloid sarcomas. However, this was a proof of principle that the use of immune checkpoint inhibitors, and in this study it was used as a monotherapy, can actually lead to clinical benefits, and started what I think was a big interest from a lot of companies as well as investigators to further study the immune checkpoint inhibitors in myeloid malignancies. So this was back when I was doing my fellowship at Hopkins, and we started, I think, the concept actually of the first study using anti-CTLA-4 in refractory MDS. So this was a study that was based on data showing that in patients with MDS, there is an upregulation of multiple immune checkpoint pathways, especially the CTLA-4, but also anti-PD-1, anti-PD-L1. And this seems to happen especially with the use of hypomethylating agents, which might suggest that this might mediate resistance to hypomethylating agents. So we started this study, which was CTIP sponsored. This was developed in Yale, which was an amazing workshop to go to. And this was actually the first time I met Pat LaRosso. She probably doesn't remember, but it was extremely good. It was extremely, yeah. It was extremely a good way to, learn how to, develop trials. And I encourage all of our fellows to try to go to it. But basically, we developed this trial where we used it as monotherapy, induction, maintenance, and follow-up. We used 2 dose levels, the 3 milligram, which is commonly used in solid tumors, as well as the 10 milligram dose. And this study took almost 4 or 5 years to finish. It was one of the first studies of immune checkpoint inhibition. And I moved it with me when I came here to Yale, where we opened it and continued to enroll on it. And at the end, we had 29 patients from Yale and 5 other centers, including Hopkins. Clinically, the results were negative. There was only 1 marrow CR in 1 patient out of 29, so very low response rate. But what we observed, and I think this also applies to several solid tumors, that some patients did achieve prolonged stable disease, which is highly unusual. As I showed you in patients with MDS, usually the disease after hypomethylating agent failure is progressive, and most patients tend to die relatively within 6 months. However, as a single-arm study, of course, it's very difficult to know for sure if this is an effect of the immune checkpoint inhibitor, or is it just an issue of the biology of the disease in the patients who were enrolled in the study. We did a nice set of correlative studies in collaboration with Leo Lusnik back at Yale. And what we found is that patients who have clinical benefit, which we defined as patients who had prolonged stable disease and the patient who had MARO-CR, had increased expression of this co-stimulator molecule, ICOS. And also we found that there was an increase in the T cell receptor diversity. However, this did not correlate with the responses. So it was very difficult to find a consistent signal that predicted response on those patients. What we did not observe was any relationship between the absolute lymphocyte count, the regulatory T cell frequency, or the CD8 Treg ratio, all of which have been suggested in some solid tumors to correlate with responses. Subsequent to that study, other studies were presented in the MDS field. This is one of the larger studies from the MD Anderson. This was presented in ASH 2018. It has not yet been published, in which azacitidine was combined with Nivolumab or Ipilimumab in patients with MDS. And like many of the studies from MD Anderson, it has multiple groups, basically. So there were frontline HMA failure, monotherapy, and combination. And they did observe some responses. However, what you can see here is that in patients, the 20 patients who received Ipilimumab after HMA failure, they had 30% response rate. Many of those were really MARO-CR or hematologic improvement. But this was quite interesting to me, since our study had a very small response rate. And I think that speaks to some of the biological and immunological heterogeneity that some of those patients have, and that it's very important to study the differences between patients when we look at those studies. However, the median survival of those patients was not actually different from our study. So monotherapy doesn't seem to work particularly well in myeloid malignancies. So the next step which was taken is to try to understand how can we overcome some of that resistance. And building on some solid tumor data that showed that in a tumor model, basically with colorectal cancer, that myeloid-derived suppressor cells seems to mediate resistance to immune checkpoint inhibition. And when the investigators added Entinostat, which is a histone deacetylase inhibitor, they noticed significant improvement in the survival of those animals who had the tumors. So we worked with TK Kemp, many of you know, before he moved to Vanderbilt, to try to see if some of those data also apply in patients with MDS. And what we actually found that myeloid-derived suppressor cells are actually increased in MDS compared to normal controls, but also they increase over time in patients who progress to AML. So there's a clear correlation between the development of disease progression and myeloid-derived suppressor cells. And then in this nice murine myeloid leukemia model, TK had shown that the animals that had knockout of the PD-1 and received Entinostat achieved the longest survival compared to the other animals, which again was intriguing in the sense that combining PD-1 inhibitor with Entinostat might actually lead to responses in some of those patients. So building on this data, basically we proposed our study combining Pembrolizumab with Entinostat for patients with MDS after hypomethylating agent failure. So this study is ongoing right now in multi-centers through the UM1 mechanism. Pat has been great in helping us getting it started, and it's accruing very well in multiple centers. And I'm hoping we just finished the dose escalation. We are now at the dose expansion. I'm hoping to have some results by early next year. This study is having a very heavy set of correlative studies that TK will be doing. Basically, he was supported by an AlloHSCT grant to look at the changes in myeloid-derived suppressor cells and PD-L1 expression. And I think, again, because many of our heme studies are somewhat smaller, trying to understand the immunological landscape is extremely important so that we can select patients better. The problem with many of those studies, as you could see, is that most of them are single arm, very difficult to make definitive conclusions. So in collaboration with pharma, Celgene led this trial, which I had the pleasure to present on behalf of my co-authors at ASH. This was the first and the only randomized study of immune checkpoint inhibition in patients with myeloid malignancies. And what you can see here is that this is really two studies in one. So it had two arms, an MDS cohort and an AML cohort. Each cohort was basically randomized separately to azacitidine, the standard of care for high-risk MDS, or azacitidine with durvalumab, which is an anti-PD-L1 inhibitor given every 4 weeks starting day one. The AML patients who were older and not candidates for intensive chemotherapy also received what is essentially a standard of care, azacitidine or azacitidine with durvalumab. So I'm going to talk about the results of the MDS cohort now and show the AML cohort later. So unfortunately, negative clinical trial on its face. Basically, the primary endpoint, which was the overall response rate, was not significantly different between the combination versus the monotherapy. As you can see, numerically higher, 61% versus 47%, but this was not statistically significant. There was no difference in the complete remission, partial remission. Marrow CR, again, appeared higher, but statistically was not significantly different. When we looked at progression-free survival and overall survival, what we can see again is that there are no differences between the two arms. In terms of the immune-related adverse events, and I think this is one of the issues we tend to have a lot in patients with hematologic malignancies, we experience some difficulties in trying to get biopsies because of the low platelet count and all of that. So there was a lot of concern about confusing fungal pneumonia with pneumonitis from the immune checkpoint inhibition and this type of thing. I think what these studies are showing that the use of immune checkpoint inhibition is actually generally safe. We are able to manage it, and we are able to rescue most of the patients who seem to have any of those side effects. Most of those side effects are along the lines of what you see in solid tumors. So moving beyond the PD-1, CTLA-4, and PD-L1 pathways, TIM3 is, I think, another novel immune checkpoint that is actually gaining a lot of attention because the expression has been shown to not to be only on the adaptive immune cells, but it's also expressed on the innate cells, and also it appears to be expressed on some of the myeloid leukemia cells, especially on the myeloid leukemia stem cells. The expression seems to worsen as the disease progresses and patients who have refractory disease. So it makes it a rational target for development of antibodies. And Novartis developed this antibody MPG453 against TIM3 inhibitor. It had nice data basically in cell lines and in animal models. And this has been taken basically to a phase 1 clinical trial in patients with high risk MDS. Again, small trial. It had 19 patients only. There were other arms with refractory ML. But in the MDS arm, 11 out of 19 patients basically achieved overall response rate. The CR rate was 26%. And this is somewhat higher than what you'd expect with azacitidine monotherapy. So I would say there is definitely an interest in pursuing this further. We work with the company actually to develop another randomized study, which is ongoing right now, which is a double-blind study basically in which hypomethylating agents are being, whether azacitidine or decitabine, are being combined with patients who receive MPG453 as well. So this study is ongoing here at Yale, and we are hoping that we are going to get some answers relatively quickly about the activity of this agent. Moving gears in the last 10 minutes or so to AML basically. So AML, many of you have heard there have been tons of drugs that have been approved in AML. Each time I give a talk about AML, I talk about before Christ and after Christ. In AML, it's before 2017 and after 2017, because we had 9 new drugs that have been approved. It has become a very congested space. Many new drugs are active, oral agents. However, what I think is very important to bear in mind is that the outcomes remain extremely poor. It's not clear how those new agents are going to actually change the outcomes of patients. But many people get surprised when I present this data. This is from SEER up to the year 2016. But AML is actually, among older patients, are worse than every single solid tumor you can have. The 1-year survival basically is less than 20%, and as you can see, compared to all other solid tumors, as well as the median survival is only 2.7 months for patients who are 65 years and older. And this really has not changed in the last 40 years. The median survival moved from 2 months to 4 months among older patients. So clearly there's a lot of need for new agents. And one of the, I think, areas where where new therapies could come in is the immune dysregulation in AML. So along the lines of the data I showed you in patients with MDS, there's a lot of immunological aberrations in patients with AML. Here, what you can see is that this is immune checkpoint pathways, inhibitory pathways. And what you can see is that in this heat map is that there is increased expression in patients with AML before treatment compared to healthy controls. And patients who seem to have increased, the responders seem to have more of the stimulatory pathways, again, suggesting that the inhibitory pathways are often present in AML and that inhibition of them make a rational combination for many trials. So several trials are ongoing, basically combining those agents, the immune checkpoint inhibitors with different agents. This is a trial from the MD Anderson group, another single arm study of 70 patients in which patients basically received azacitidine in the relapse setting with Nivolumab. And what you can see is that the response rate was 33%. The authors compared it to a historical control from the MD Anderson as well to a study that we actually published, a large retrospective data set, the largest of hypomethylating agents in refractory AML patients. And what they found is that the response rate as well as the survival appears to be somewhat better. Of course, very difficult to know from a single arm study. They found some predictors of response, such as the lack of receive of hypomethylating agents, as well as increase in the CD3 ratio. So basically, the more T cells you have in the bone marrow, the more likely you are to respond. So the same study I just showed you, the Fusion 001 study, this is, again, the first and the only randomized study in, with immune checkpoint inhibition that has reported so far. When we looked at the AML arm of 130 patients who were randomized basically to the combination, similarly, the results were negative on its face. So there was no significant differences basically in the overall response rate or in the complete response or complete response with incomplete count recovery. All of those were not different, and complete overlap between the progression-free survival between the two arms and the overall survival. And I think one of the reasons why I really like to highlight this data, although it's a negative study, two parts. I think this highlights the importance of randomization. For example, what I show you here is that the overall survival with azacitidine alone in this trial was 14.4 months. Most of the trials in older unfit patients who receive azacitidine, the survival is less than 11 months. So if this was a single arm study in which someone told you a combination has 14 months, you would be excited, but that's because you don't have a randomized arm. Here, what you can see is that even the single agent azacitidine had a 14-month survival. So I think this highlights the power of randomization that I think is very important. But also it allows us to understand some of the immunological changes at baseline in many of those patients and how things change with treatment. So the overriding theory is that azacitidine as a hypomethylating agent will lead to hypomethylation of the promoters for multiple immune checkpoint inhibitors, including the PD-L1, and that the increased expression with azacitidine might make it more vulnerable to inhibition with the immune checkpoint inhibitor. So what was observed in this trial that with therapy that there was indeed increased expression of the PD-L1. However, this only occurred in the bone marrow microenvironment in the granulocytes and the monocytes, but not on the plasma cells. And azacitidine did lead to significant global hypomethylation in the majority of patients, which is somewhat expected within the context of this trial, but again, did not correlate with any specific responses. This was the first data set that we just presented. There's another abstract being prepared for EHA that is actually focused on the translational studies from this trial, which I think will have very important information. So the next point of interest was how about combining intensive chemotherapy? All what I showed you so far has been hypomethylating agents. How about combining intensive chemotherapy with those agents, immune checkpoint inhibition? This is a study from the MD Anderson single arm study, 44 patients in which they combined their standard intensive chemo with Nivolumab, and they found 78% response rate. 50% of those patients were MRD negative. So this appears slightly better than what you would expect. However, the survival compared to historical control was not much better. So it's not very clear, again, whether there was a benefit or not. As many of you know, in the context of solid tumors and lung cancer, there have been several studies that combine intensive chemo with immune checkpoint inhibition. And the idea there is that when you give intensive chemo, you get all this antigen release, and it's a prime time for the immune system activation. So you want to have the immune checkpoint inhibitor so you can augment your T cell response. So in that context, Prajwal Bodhu, one of our brightest fellows, has been working with me to develop this trial program, really what we call the BLAST MRD-ML program. So this is a series of 3 trials. All of them are approved already by the first one is approved by the CIRB and CTIP. The second one is approved by CTIP and is currently being looked at the CIRB. And the third one is an investigator-initiated study supported by Merck, the Pembro maker, basically. So these 3 studies, we are hoping to enroll 300 patients, basically in multicenter setting. So this is the schema of the first one, of the first study, the BLAST AML1, in which patients will be randomized between the standard treatment 7+3 versus 7+3 with Pembro. And the primary endpoint would be basically not only complete remission, but what we call MRD negative, basically not having any measurable residual disease. Why is that important? Because we have a lot of data basically that having MRD negative CR is really the best response that you can get in acute leukemia treatment, and trying to get there is something I think that is clearly showing to be very important. However, MRD is a function really of the depth of the assays you are using. So we are collaborating with Dr. Jerry Radich and the Hutch basically to use a very, I think, novel platform called duplex sequencing, which increases the depth of recognition of the MRD status basically from the next-gen sequencing of 1% to 1 in 100,000. And I think that's going to be very important to try to delineate not only that you not looking only at the overall response rate, which many studies did, and I think it's probably not the best endpoint to look at, but you want to look at the depth of the response, the durability of the response, and not only in the context of immunotherapy, but also in the context of how MRD negativity translates into long-term outcomes. This is a busy table, but it's showing all the immune correlative studies that we'll be doing. This will be done within the CMAC, the Cancer Immunotherapy Monitoring Group of the, as you can see here, all the collaborative investigators will be looking at a large number of data sets, including specific immune activation panels, DNA methylation, cytokine panels, whole exome sequencing, RNA sequencing, and TCR diversity, in addition to single cell and circulating tumor DNA. And in collaboration with Novartis, we are also pursuing a STIMULUS-AML trial in which azacitidine and venetoclax is being combined with the MPG, the anti-TIM3, in the frontline setting for older patients with AML. Another, I think, novel immune checkpoint inhibitor is the CD47. This is what we call don't eat me signal. It's present in many of the normal cells to make the macrophages realize that this is a normal cell and do not basically engulf it. And there is a lot of data that in MDS and AML, there's increased expression of the CD47 on many of the leukemia and the AML cells. So we had a phase 1 trial here of CC9002 that we just presented in the past ASH meeting. It was a negative study. However, another molecule called Magrolimab is actually showing activity in combination with azacitidine. So I do think that there appears to be some interest in pursuing this further. In the last couple of slides, basically, I'm just going to show you one other trial we have been working on for some time. Many patients are on tyrosine kinase inhibitors for chronic myeloid leukemia. However, those drugs are generally given for life. They cause a lot of side effects and a lot of cost. And there has been a lot of interest in discontinuing them. What has been found is around 40% of patients with deep remissions, with deep molecular remissions, are able to discontinue those agents and not have the leukemia come back. However, the other 60%, the leukemia is coming back. And there is increasing laboratory evidence that some of that is related to T-cell exhaustion, that those patients are not able to clear the cells basically with, which carry the translocation. So this is an ECOG trial that is currently ongoing in which we combine Pembrolizumab with any of the TKIs. And the idea here, again, is to convert patients who have minimal residual disease into MRD negativity, and then try to stop the TKI and increase their ability to have this therapy-free remission. This is the last couple of slides I have. Is basically, this is a study that Rory Chalice has done here, looking at the use of immune checkpoint blockade for patients with myeloid malignancy. This was a retrospective analysis of all of our patients who went into those agents. And the idea was to try to understand the challenges that we have compared to solid tumors. And what we found is that things related to whether our patients develop a fungal pneumonia, which is quite common, or do they have pneumonitis, has been one of the issues that we always were concerned about, because we cannot get biopsies easily. It's very difficult to do a bronchoscopy. It's very difficult to do a colonoscopy in many of our patients who have low ANC and low platelets. However, what we found is that most of our patients have been managed well in terms of quick interventions, and it's very rare to find any patient who dies from those severe immune-related adverse effects. So I think in principle, it's clear that we are able to conduct these studies. We just need to design better studies that incorporate molecular markers that have, I think, randomization and better correlative studies to understand what's happening at the biological level of the tumor. So at the end, I'd like to recognize all my colleagues here, especially Steve Gore and everybody in the section, our CTO team and our collaborators. Pat has been instrumental in getting many of those CTIP trials going, our colleagues in CTIP, and all our wonderful fellows who've been doing amazing work with us, as well as all the funding organizations, especially the Leukemia Lymphoma Society for the Scholar and Clinical Research Award. Happy to take any questions. Thank you.
Thank you. I know we're a little short on time. Maybe a question or two. Any questions from the audience? So, demethylating agents do lots of things. And if you think about what you want them to do over the next decade to make immunotherapy work better in these diseases, what would be the principal target you're looking for these drugs to hit?
Yeah, that's a great question. Actually, Steve is in the audience. He always hates calling them hypomethylating agents, because many of us do call them this, but we actually don't even have any real definitive proof that this is how they actually cause their beneficial effects in tumors. It has been always the theory that hypomethylating of certain tumors, suppressor genes and other elements are what leads to the response. So I think one of the important aspects in trial development is to try to move away from this traditional empiric combination. You have something that works and add P and X, and this is how many of our studies have been done into situations where you're actually making the combinations more rational, and I think that's the way to go in general.
Thank you.
Sure.
Well, just if people have questions, Amer, we'll let them ask you at the end. So thank you.
Yeah,
Great
thank
you. So our second speaker is Dr. Michael Cecchini. Michael, as you may know, is a proud alum of